everyone. Thank you for coming. Thank you for being here tonight. My name is Deb Zaveri. I'm the new president of the San Diego chapter of TiE, the TiE South Coast, as we call it. So I've actually been a member or a charter member since the early 2000s when we used to meet at the La Jolla Women's Club. And so you can see how many years it took me to earn my way to this coast, and hopefully I won't disappoint. We also have a new executive director. There are a lot of changes in our chapter this year. Mary is somewhere over there in the back. Say hi to Mary Cristiani. She is the new face of TiE. And our immediate past president, well, a lot of our past presidents are here, but Sandeep is here somewhere. He is amazing. Thank you so much. He's the best president of women could ask for. Thank you. Or president could ask for. Thank you. Thank you to you and your entire team, Sandeep. Okay, so we are. How many people are here for the first time at a TiE event for the first time? Wow. Great. Okay, great.
Yeah.
So we meet on the fourth Tuesday of every month, and of course in November, December, that we mix it up a little bit. But we have different events. We try to target 3 events in the biotech, 3 events in the telecom, and just to not be siloed. We have 3 events in completely different fields. Last year, Sandeep and crew hosted a great event on the cannabis industry in San Diego. This year, we plan on having some in the real estate industry and a couple other topics. So we try to keep it interesting and mix it up, and hope you'll join. We also have charter members. I believe we have a new charter member in the room today. Angela, are you in here? More than me. Hi, Angela. She's our latest charter member, and Angela actually, she is new to San Diego, moved from Chicago, and she's an architect. So we like, and I'm actually an attorney, so we like to, a lot of chapters, if you've been involved in other TiE chapters, it's a little more, it makes biotech, telecom, but our chapter in San Diego, for a variety of reasons, we like to have people from different backgrounds, hopefully mix it up and keep things enriching. TiE is the largest worldwide entrepreneurial organization per The Economist magazine. We have over 60 chapters in about 17 countries. So, and it is wonderful. I have just been a president for about a month, but I get emails from people in all different parts of the world saying, do you know anyone that does this? Do you know anyone that does that in that part of the world? And so it's just a great way to get to know people. And I used to work at a big international law firm, and he's kind of reminding me of that. Like, oh, if your company has any interest in going into Kazakhstan, TiE might be able to help you out. That's not a joke. So thank you to J&J, thank you to Abhay Kumar. Our next speaker, we're going to have Steve Morley, one of our members, speak real quick about our next event. And one of the pillars of TiE is investing. So our next event is on investing, 4th Tuesday, February 26th at 5:30. Steve's going to talk a little bit about that before our distinguished panelists.
Perfect. Well, thank you all for coming. We are going to have a fantastic conversation. The topic, cell therapy, you probably have heard a lot about this already, but it is sometimes called the living drug. Now, if you think about cancer, that's one of the formidable challenges of our time. It's a disease that kills about 5.5 million Americans every year. And then over time, although we have made a lot of progress, if you think about going back in time, there was surgery, there was chemotherapy, and then there was radiation therapy. And when you're dealing with a challenge of this scale, you have to rely on these scientific breakthroughs. The important thing to learn about this opportunity here is that cell therapy is one of the latest breakthroughs. A few years ago, when this was in its infancy, it was almost thought as work of science fiction. It never happened. But now you would hear, I have just a couple of slides to introduce the subject. You would see that the therapy itself has come so far, and there's so much money going into it. So we'll discuss the panel why this is becoming such an important issue of our time and what we can do. And the therapy itself isn't just limited to cancer. it can be applied to all kinds of disorders, including neuromuscular disorders. With the demographic shift in the audience, you can imagine that we would have more incidence of Alzheimer's, Parkinson's, and many other similar disorders, and we need to be prepared. We used to think a few years ago that those are in the future. It's not going to happen, but now it's here and now. The incidence of Alzheimer's is already increasing, and we need to be fully prepared to deal with those kind of disorders. So let me quickly go over, just to level set, so we are all on the same page. What is cell therapy? As I said, it is your own cells that can defeat the disease that is afflicting you. So sometimes it's called living drug. I don't know if this works or it does. So think about the patient itself. Patient on the left side, you isolate the cells, and then you select some of the cells which are going to be relevant. I don't know if you can hear me. Select those cells, and then you engineer those cells. Either you put a modifying agent in those cells, or you put a gene in there that will target those cells to take care of the cancer. The cells, I put down immune cells, your body's own immune system. Think about the police in the city. They are roaming around, and when they see an intruder or miscreant, they gather and then they kill or take care of an individual. So something like that, your body's own immune system is geared to take care of it. What this technology does is harness the power. So this is very simplistic. Obviously, a lot goes behind the scene. There's a lot more technicality, but for the purpose of our discussion, we probably wouldn't have time to go through all of that. So you look at these cells in step 3, you activate them, and then you expand them in large numbers, just like police force. All the police cars will come and take care of things. Much along the same lines, now you have the good guys in large numbers, and you put them back into the patient. Now, one thing you would hear over and over again, perhaps here or maybe elsewhere, there are two kinds. What we call is one-to-one, meaning same patient cells, they go back to the same individual. Or you can take the cells from one individual and give to multiple other people. So one-to-many is what we call allogeneic, or for the simplicity, one-to-many, or one-to-one is autologous. That's what the distinction one will have to make. So there are nearly 800 companies. Let me just go to the next slide. This is the data from the Alliance for Regenerative Medicine. So there are 861, and this data is a little bit dated, a little bit old. About 800 plus companies which are currently in this space. The global funding, just in Q1 of last year, it was close to $3.8 billion. In terms of the trials, you can see 900 plus trials ongoing. In fact, FDA commissioner just put out a report 2 or 3 days ago, or maybe last week, and he said that they are gearing up for increased number of INDs. There are already 800 INDs. So IND is a term that is used by the pharmaceutical companies when they are filing for new drugs. Already 800 on file, and they are expecting 200 more by 2020. And by 2025, they are expecting 10 to 20 new drugs approved. So FDA, this is new. They are not ready for it. So they are gearing up. They're putting resources behind it. So you can see when government is taking action, how serious this must be or it's going to become. Just the number of trials, it's got in the last 5 years, there are 4 times as many trials which are ongoing today. So there is tremendous interest in the marketplace about cell therapy. And the reason is that there are some success stories which I was going to tell you about. So here is a story of this young lady, 12 years old now. She has been cancer-free for the last 6 years. So Emily Whitehead, when she was first detected with cancer, ALL, or a kind of a leukemia, all hopes were given up. The parents were obviously devastated. She was 5 or 6 years old back then. They didn't know exactly what to do, and that's when Novartis was gearing up a trial based on cell therapy, very new. Nobody really believed in it, but they really, as any parent would do, want to do the best for their child. So, long story short, 6 years later, she is completely cancer-free. There's complete cure. We're not talking about managing cancer. It is complete cure. There is no trace of cancer left in her. And so this is a picture. We have permission to use this picture and this is story. I didn't say that I work for Thermo Fisher Scientific. It's one of the companies which is very active in this space. Hence my interest in this space, and I'm following this very closely. Today we have a panel of distinguished professionals. I have to say from the get-go, one of them is snowed in Utah. There was an avalanche yesterday and she couldn't make it. Kim calmed out. But we have Paul Lycan, who's in the audience. I'll request him to come join us. And we have Hari in the audience, who I request him to join us. The fourth panelist, Keith Barry Simon. He is on his way from LA, so we are hoping he can make it. But coming from LA, he can never. Please come in. I would request. I request Paul and Hari to introduce themselves and also about your organizations, how you got involved in this, and when you started your company, what were you thinking, and how far have you come to that achievement?
Oh, that was a lot. All right, well, maybe I'll get started. So first off, I've got to correct you on one thing, just as the last speaker corrected your president. What was shown up there was one aspect of cell therapy. Okay, that is autologous cell therapy, where you take the patient's own cells, modify them, give them back to the patients. But there's a lot of other types of cell therapy. There's induced pluripotent stem cells, where you take a cell from that patient, you drive it to an embryonic stem cell state, and then drive it to become another cell, and then replace that. That's also can be an autologous approach. Or allogenic, which means that it's a human cell, but not necessarily that patient cell. And then there's what the company that I work with is doing, which is starting with a stem cell bank, in our case an embryonic stem cell bank that we had isolated years ago, and then using that to produce that embryonic stem cell can go on to become any cell in the body. So if you can learn to drive it to a type of cell, then you can use that to replace cells. So that's another type of cell therapy that in those clinical trials you saw out there, a number of them are in that area as well. So I'm Paul Lycan. I'm president and CEO of ViaCyte. I've been in the biotech industry in San Diego for about 35 years. Started three other companies here that went public and were acquired. Interestingly, you asked what was my goal when I started the company, etc. I didn't start ViaCyte. This is the first company I've run that I didn't start. I really recommend that, by the way. Yeah, so I joined ViaCyte about 7 years ago, but the company's been around for over a dozen years. In fact, 3 companies were merged together in 2005 to form the current company. So if you trace those all back, it goes back to when we were all pretty young. But the company really in the last 12 years has been really focused on 2 things. One is a really laser focus on delivering a cure for type 1 diabetes. Not treatment, not therapy, but a cure for type 1 diabetes, and that's really exciting. And then the other thing that we've been focused on is really developing this whole field of stem cell derived cell replacement so that it can be used not just for type 1 diabetes, but for type 2 diabetes and many other diseases out there. So ViaCyte, we said we'd keep this short, so I'll make this a quick review of where ViaCyte is. So ViaCyte is a company, the way we are going about to do those 2 things, as I said, we start with an embryonic stem cell. We take that stem cell and we learn, after about 7 years of hard work, how to drive that stem cell to become a pancreatic cell. So in type 1 diabetes, for cell replacement therapy, type 1 diabetes is kind of the low-hanging fruit. It's an autoimmune disease where the beta cells in your pancreas are destroyed and it's no longer able to produce insulin. 100 years ago, type 1 diabetes was a fatal disease. Insulin turned it into a chronic disease. But for 100 years, it really hasn't changed the therapy. We still treat with insulin. We're got better insulins. We have better ways of measuring it. But at the end of the day, we're still doing the same thing. And there's a lot of long-term complications and impact on quality of life from the disease. So what we're doing is we're taking these stem cells, we're driving them to become a pancreatic cell. We then put them inside a device, and we have different devices with different activities. But we put in a device, you can think of this like a tea bag. It's a thin, small device, the cells are inside, and then that gets implanted under the skin subcutaneously. And it's designed that it's vascularized and those cells then mature inside that tea bag, if you will, to become islet tissue. So beta cells that produce insulin, alpha cells produce glucagon, cells that produce somatostatin, the full complement of the normal pancreatic islet. And so the idea is once this is implanted, those cells mature, they produce insulin and such, and they correct the disease. We know you can do this because it's been done with cadaver islets. You can take islets from cadavers, purify them, and implant them into a patient with type 1 diabetes, and essentially give a functional cure that can go for the first patient was treated with this about 18 years ago, is still insulin independent today. And most patients will go about 5 years or longer insulin independent. So we know you can do it. There's very limited supply of those types of cells, and there's a lot of complications with that. So by using this stem cell source, we hope to be able to make this available to all patients with type 1 diabetes, even insulin requiring type 2s. So where we are as a company, we're in the clinic with 2 products right now. One for high-risk type 1 diabetic patients that requires immune suppression along with it, and a second product that is designed to protect the cells from the host immune system to open it up to all patients with type 1 diabetes. And then we have a third project that we just did with a gene editing company, CRISPR Therapeutics, where we're working to engineer our stem cell line to be immunogenic so that we can essentially be immune evasive so that we can then use this for not only diabetes but many other diseases. So that's in a nutshell kind of where we are right now. We're a private company. The financing has come from the venture community. Also, we've had a lot of funding from the CIRM, the California Institute of Regenerative Medicine, put about $70 million into these projects. JDRF, the Juvenile Diabetes Research Foundation, has put $15 million into the projects. And we just did a private equity round at the end of last year that put another $80 million into the coffers. So we're hard at work, and we hope over the next couple of years to deliver that cure and move this food.
Great. Thank you. Back to you.
When are you in clinic?
Pardon me?
How long?
We're in a phase 1-2 trial on the first product and a phase 1 going into 2 trial on the second. Let's hold the questions until we do the other end.
Absolutely.
Well, that was such a fascinating story. I think I'd rather personally just move straight to the questions. I am sort of I would say the least illustrious member of this panel. The 2 missing members who are here, I'd still be the least illustrious member. I am my name is Sri Sepa, a physician, scientist. I have worked for the last 5 or 6 years, just one mesa over across the street at JLabs, Novartis funded institute that does drug development and early stage discovery science. I also practice over at UCSD. I'm a musculoskeletal radiologist working on imaging and interference therapy of primarily musculoskeletal disorders. So I run a research lab at GNF together with my brother Shrinath, who's here in the third row in the red sweater. In case you're looking at him in a confused way, yes, we are twins. Actually, just interesting coincidence, just today, Shrinath and I gave notice that we are leaving GNF, so we're moving into another phase of our careers. So it's an interesting time to be on this one. I've been interested for many, many years in cell-based therapy. The lab that came from postdoc in conducted the first trials for human cell-based therapy in muscle diseases and Duchenne muscular dystrophy, a really crippling inherited form of myopathy. Our lab has had an interest in developing new approaches to cell-based therapy in muscle as well. And I think it's an interesting counterpoint to what Paul was talking about. We're both, I think, in the business of thinking about cell replacement therapies, which is not what most people think about when they think about cell-based therapies, at least not in the post-CAR T world. And I hope one of the things that we can dig into is really what the disparate challenges are in the sort of cancer CAR T regime versus the cell-based therapy regime. I think for a person like me who considers himself a stem cell biologist, it raises many interesting questions about what, the question of what type of cell you're trying to put into a person, but also what kind of environment those cells face and what the prospects are for persistence and achieving a therapeutic effect, what the barriers are. So perhaps we can get into some of that in the course of the discussion.
Thank you both. The format for our conversation is free-flowing. Please jump in with your questions when you think is appropriate. And we are all in it together. We all want to learn. Maybe I'll start with a question for both of you. Paul, you mentioned about type 1 diabetes, that's where your company is focused on. Now, could this technology, or how we envision this technology, be applicable to other autoimmune disorders, which is becoming really an important issue for you to overtake cancer at some point in terms of the morbidity.
Yeah. So I just want to pick up on one thing. I'll get to your question, Sarah, but one thing you said, which is, we're both of us are sitting up here talking about cell replacement therapy. And so CAR T, you mentioned that kind of the post-CAR T world. It's really interesting because I'm on the board of the Alliance for Regenerative Medicine. You saw some statistics from that organization. When that organization was set up, it was all about cell therapy, cell replacement therapy. That's what the focus was. CAR T came along, and now it's all about CAR T, autologous therapies for cancer, and for good reason. This has really been a sea change in our industry over the last, let's call it the last decade. If you go back to just 2013, Onyx Therapeutics got a drug approved for multiple myeloma. The indication for that and what they got it approved on was patients that would live for 3 years would now live for up to 4.5 years. Okay? And that was what the approval was for. And that product was a very expensive product, very important, and very exciting for the field. 5 years later, now we're talking about cures with CAR T and other approaches, and therapeutic approaches. So there really has been a sea change, and it's really exciting. So to your question, I think on the cell replacement therapy, we've spent a lot of time at our company working with the stem cell bank that we have. We isolated this bank a number of years ago. It's been thoroughly tested, evaluated. We've been in front of regulators in the US and Canada. We just started a clinical trial in Europe in November. So we've been in front of regulators throughout the world with this bank of cells. Okay? And this bank of cells is inexhaustible. Okay? We have a master working cell bank. We take from that and working cell bank. And it gives us an unlimited supply of starting material for making cells. As I said earlier, an embryonic stem cell, if you know how to manipulate it, if you know how to do the work, if you understand how the disease, how the cells are formed in the embryo, you can drive that cell to become any cell in the body. Okay? So you can use your imagination in terms of when you talk about how this could apply and how this could change medicine down the road. Okay? So, and that's what we're looking at. We're looking at ways, as I said, to take that cell bank and modify it using gene editing, which brings in a whole other technology that everybody's very excited about, to make that more immunogenic or immune-invasive, which would open this up further. But it's a lot of work. The work that we've done to drive from embryonic stem cell or stem cell up to a pancreatic cell, and the products are working. We have over 700 issued patents. 150 patents that issued last year. So you can see a lot of work has gone into that, a lot of invention has to come to do that. But when you figure it out, it opens up a vast array of opportunities.
Absolutely.
I would just add on to that also, you mentioned specifically autoimmune diseases or inflammatory diseases, I guess more generally. It's important to, as you look at the landscape of opportunities, to ask, what are the diseases where we're really sure we know what the operative cell type is? Because that is not always obvious. If you look at rheumatoid arthritis, that's an autoimmune joint destruction. Just as a hypothetical, say you wanted to take a cell therapy approach to rheumatoid arthritis to restore the damaged joint. What cell type would you propose to put in there? And what state would it be in? And how would it be engrafted? And what would you be asking it to do? So I think the opportunities lie, at least at the beginning, certainly in the diseases where we really believe, because there's a deep bank of science, basic science to draw on, that we understand what the cell type is that's affected, and ideally that's a relatively defined cell type, and we know from preclinical models that replacing it really just does restore function.
Yeah, that's exactly right. That's why I said type 1 diabetes is kind of low-hanging fruit in this space, because
Not particularly low, but
yeah, but it's from the point of view of we know exactly what we need to replace. In rheumatoid arthritis and other diseases, there's still a lot of work to figure it out, but it'll get figured out. I'm confident over time, especially as we have the tools that once it's figured out, we can use these tools and then go and treat it.
I see some questions in the audience.
Is cell therapy and immunotherapy the same thing? And if they are not, what is the difference?
No. I think they're not the same thing. I think that there may be some overlap in some instances, and you see that a lot actually in some of the work that's been done in musculoskeletal diseases. There's a long history, fairly checkered, of people trying to do, for instance, mesenchymal stem cell transplantation for various sorts of degenerative disorders of the musculoskeletal system. And a lot of this has been irreproducible, even in preclinical models. A lot of it has failed to translate what little light has been thrown amongst all this heat. One of the major learnings has been that when you put cells into any environment, they start to secrete factors, and they have some immunomodulatory functions. So you can get clinically apparent benefit from injecting a cell that does not persist where you inject it, and it's gone when you try to look at it weeks or months later. What that probably is some sort of local immunomodulatory environment that's created by those cells for a brief period of time that has some therapeutic benefit. But for the most part, when people talk about immunotherapy per se, they're really talking about drugging the immune system, using monoclonal antibodies, for instance, to activate or deactivate different portions of the immune response.
Yeah, I'd say, first off, I'm really glad you said that about stem cells. One of the things I usually say, especially to an audience like this, is that we don't treat with a stem cell. In fact, we go to great lengths to make sure there are no stem cells left in the therapy that we administer to a patient. There's a lot you hear about on stem cell clinics and such. That's not what we're doing, and we have the FDA has real problems with those, and a lot of people have. So I agree with what he said. There is an overlap, okay, in cell therapy and immunotherapy. So you've heard the word CAR T. So what is CAR T? Okay, so CAR T is a technology, and I'm not an expert in this, but basically it's a way of taking, as was shown in the first slide he showed, taking cells from a patient, essentially isolating certain immune cells, what's called T cells, and introducing, using a gene therapy approach, a factor into those cells. And actually it's CD19, which is a surface protein on those cells that activates the immune system. And so that's the immunoactivation part of it. And those cells are then taken, purified, put back into the patient, and they basically wrap up to the patient's immune system so that it recognizes the cancer cells and eliminates it. It's very effective. So it is a cell, there is an overlap. That's, you can say that's a cell therapy because you're taking cells, you're modifying and putting them in, but it's also an immune therapy. Immune therapy covers a lot of things, not just that.
I think it's a really interesting point you made about the need to actually get rid of the stem cells from your preparation. And that goes to what I think is a really curious divide in this cell therapy space. On the one hand, you have the the restorative therapy or regenerative medicine type approaches, cell replacement therapies, that generally speaking have very, very little in the way of toxicity potential, but it can be hard to prove that there's any kind of an efficacy readout either. And then on the other hand, you have cancer therapies like CAR-T cell therapies that have very, very high, and in some cases, as you were pointing out in the case of Emily Whitehead, astonishing levels of clinical activity, but very significant toxicities associated with it. So cytokine release syndrome being the pertinent one for CAR-T therapies. And then I think there's the in-between again is something that's iPSC derived, where there's a theoretical risk of tumor formation, and that's where you get the question of trying to get rid of the pluripotent cells that are in the extreme.
Question in the back.
Given that diabetes is an autoimmune disease, what would stop the body from attacking your new cells once they're released from your T bag?
So there's really, so we use, as I said, what's called an allogeneic approach, which means they're human cells, but they're not the patient cells. So in any disease, if you were to use an allogeneic cell therapy, you have to worry about rejection of the cells because, again, it's not your cells. Okay? It's not as tough as putting it in a different species, which is what's called a xenotransplant, and that's a really difficult approach. But so in allogeneic transplants, you have to prevent that rejection. In the case of type 1 diabetes, you also have the autoimmune rejection. Okay? So a lot of people talk about using induced pluripotent stem cells, and the advantage of that is potentially you take a cell, a skin cell from a patient, you drive it to an embryonic type state, and then you drive it back up to a pancreatic cell and you implant that. Now it's not allogeneic, it's the patient's cells. For the type 1 diabetes, it's an autoimmune disease, so you still have it. So in our case, the way we do that, as I said, we have 2 products in the clinic. One, the cells are in a device that has ports and openings that allow direct vascularization, so it makes for a very robust engraftment, but that has to be used with immunosuppression. And then immunosuppression will suppress both the allogeneic and the autoimmune, the adaptive immune system. So that one is only useful for really high-risk patients. About 10% of type 1 diabetes fall in that high-risk category. Still a large number of patients worldwide. What we are doing for the rest of the patients is that T-bag approach I said, basically using a membrane that now prevents any cell-cell interaction. And in order to get that either an allogeneic or an autoimmune rejection, there has to be an interaction between the cells that we're implanting and the host's immune system, essentially the helper T cells. So we block that using this membrane that allows diffusion of oxygen, nutrients, proteins can go across membrane, but cells cannot. It makes it a more difficult product because you have to get a vascular network set up on the surface of that device and then diffusion across it for your cells to be effective. And that sets up some challenges with regards to the body's response to that device and such. So that's what we have to work to overcome. One of the interesting things about cell therapy is you do a lot of your research in patients. You do work to get to the patients, but once you get into the clinic, it's not right into clinical development. You're into clinical research and optimization, and once you optimize, then it's good.
Question?
Yes, can you say something about cell therapy for degenerative knee replacement?
Yeah, there's a ton of interest in that. This is something that I see a whole lot of in my practice. I have to say, I've also seen a lot of people that have had crazy things injected into their knees based on pseudoscience of what cells are responsible for the degenerative process. And I think it comes down to the question we were discussing before, which is what are the cells, if there are any, that give rise, or whose lack gives rise to the disease we know as osteoarthritis. In many cases, I think it's impossible to say because the primary abnormality is actually a structural one, so the anatomy is bad. If you tear your meniscus, there's no way of putting a cell type into your joint that's going to repair
The
that.
claim is that it regenerates the cartilage.
So that's the claim, right? And so
Based on no controlled studies.
exactly. And
Because you're regenerating dendritic cells, right? Not the
We're
stem cell.
we're very mechanistically focused. We know
Well,
exactly.
that's what I'm asking. Is there such a thing going on for?
there are many people that are working on it. I have a fair degree of skepticism that, for instance, in the case of people, in the case of a typical patient with, let's take a garden variety medial compartment osteoarthritis of the knee that's usually related to, say, a degenerative meniscal tear, I have extreme skepticism that any kind of a cell therapy approach in that context can have long-term efficacy without having some sort of procedure done to repair the underlying abnormal anatomy, which is to say the meniscal defect.
In the last few months, we have heard about these reports. The stem cell therapy clinics are popping up all over Mexico or even in India. I think you want to get in there with your eye wide open. They've not proven therapies. They've not done adequate studies. And it's just a warning for all of us when the subject is so important. There are folks who are willing to take advantage of individuals who need help. And so we just got to be very careful about that.
Yeah, and I think in that context, I would just say, we're all, some of us are physicians, we're all patients. And so we see, in ourselves, our family members, people that are suffering with arthritis or other diseases. And you see the level of desperation in some cases for something to be done. And so if you have a therapy that has very, very little or no known risks associated with it, or at least no severe risks, and at least a hint of possible efficacy, people go for it. They just go for it. I don't think much about it. And I have nothing really to say about that, but from a scientific point of view, I don't think there's much support there.
It's not to say that it doesn't work for some people. The placebo effect is a real effect. But, all kidding aside, placebo effect is real. Okay? If you go into a patient, you treat them, you give them a treatment and all, they can improve based on a placebo effect. Now, put them into a well-controlled clinical trial with multiple patients and blinded and all, oftentimes it won't play out. But that placebo effect is a real effect.
Yeah, I've personally injected many patients. They bring in their vial of Synvisc to inject in their knee. Maybe somebody in the audience has had this done. There are people that absolutely swear by this, absolutely swear by it, and they get it injected over and over and over in their knee without really any understanding of how long it's there, what it's doing, how it could be doing it.
Did you have a comment?
Yeah. So I'm thinking of Dendron's product for prostate cancer. I'm not very familiar with the product, so I will just talk about my impression of the product. I feel it was very cumbersome for the patient. They had to go to these centers and harvest the cells, etc. I thought it was very expensive, and I thought the efficacy for that particular product wasn't that great. The next generation of prostate cancer has more applications. So, how do we get away from the first two, expense and convenience for the patient? I'm assuming the efficacy will be there for the new next generation product, but you still have the convenience and the expense there.
Well, certainly, I mean, it's a great point. The case that you brought up, Provenge, it's a bad combination to be expensive and have low efficacy. And inconvenient. The old thing of, good, faster, cheap, pick two. You should should at least have one. Yeah, I don't know. I think that it probably starts by picking the right disease. And I think, Paul, your company is a good example of this. I mean, if you cannot reduce it to practice for a disease where there's clear need, you know how to measure the outcome, you know the cell type responsible, and you know what the steps at least look like on a whiteboard, it's hard to imagine achieving success everywhere else.
Yeah, so the first talk you talked about was convenience and price. So convenience is right now, a lot of these cancer therapies and such are autologous, as we already discussed, where you're using the patient's own cells, and you're right, they have to come in, they have to be harvested, it's very expensive. It's also, it's taken, a sea change in the pharmaceutical business model to be able to accommodate that. When this first came out, companies were like, well, this will never work, it's too expensive, too cumbersome to do it, but it works, and it can be a cure for patients. The drug that was mentioned at the beginning with the little girl from Novartis, the cost of that drug is $475,000 for treatment. So one of the big challenges in this field is pricing and how do you pay for these. And the problem, the trick is these are potentially curative. We're talking about things to cure type 1 diabetes or to cure cancer. So, there's obviously tremendous value in that, long-term value, but we work in a reimbursement environment and the payer environment that looks very short-term. Okay, they have the patient, in their insurance pool for a few years before they move to another company and go to a different insurance pool. So, to have to put out, $500,000 to $1 million for the treatment is really problematic. So there's a lot of work, actually. The Alliance for Regenerative Medicine did 3 white papers on this that were published in Vivo last year. And if anybody's interested in this, I highly recommend you go take a look at that. They identified the problem, they looked at various ways of addressing it, and then put forth some steps forward on that. So there's pay for performance models where you basically say, okay, you're going to pay $500,000, but if it doesn't work, the company's going to rebate back your money or some way of doing it. There's annuities and reinsurance models and such. Kind of pays, almost like buying a car and such. I always wonder how you repossess in this phase. So there's a lot of work going into the whole part of the paying. Back on the treatments and making it more convenient, that gets into what we've been talking about. Most companies that are doing autologous are working on allogeneic. Sometimes they call them off-the-shelf cells, where they can take a cell, engineer it, and use that cell for multiple patients. And that now changes the whole environment, changes the way you treat the patients, and change the pricing and such. So that's certainly an area that's being heavily worked on. I've already mentioned a couple times we're working on that with gene editing, but we're certainly not the only group out there that's doing this. There are many groups that are looking to do that, to make cells that you can use a universal cell.
It should also be said that the concept of convenience is a little bit in the eye of the beholder. So if you ask me, getting a bone marrow biopsy is not convenient. On the other hand, for a patient that has a severe degenerative disease or neurological disease, getting a bone marrow aspirate to access bone marrow mesenchymal stem cells or whatever it might have to be, or if you're moving towards hematopoietic stem cell transplantation, this is not a big deal. Right? I mean, people are more than willing to do this. And so there's no one answer for the question of convenience. It really has to be put into the context of what the diseases that we're talking about. And with regard to cost, a lot of the procedures that we're talking about, that have been mentioned today, that are being done out in the community, these are being done on a cash basis. So these are things that are just being paid for out of pocket. Now that doesn't really translate when you're talking about serious life-threatening illnesses that have to be treated over the course of many, many years and have many other comorbidities. So it's really context, I think.
When you're working with an allogeneic treatment, what role does the patient's genotype have? And do you have to match that up? And, you know, when you're working with a lab rat, you've got a perfect, you've got the same phenotype, you've got the same genotype, and you even have the same genetic characteristics. So how do you deal with that? And do you reject some patients because they don't have the right genotype?
So we don't, okay, but what you're talking about is certainly another area of interest. There are these universal banks where they're doing different HLA types, the characteristics of cells, and trying to isolate, 90% of the types of cells so that you can go to that bank and choose a cell that is likely to work in a particular patient. That's one approach. In our case, because we're protecting the cells from the immune system and essentially walling them off, if you will, from the host system with our device, we don't have to worry about that. Basically, the cells, the patients, it's independent of the patient.
Great point. I got for this question today. So, go ahead.
For Paul, because the device is encapsulated, the cells are encapsulated and immunoevasive, is there any worry about these cells becoming transformed and possibly malignant? And then the second question is, in clinical trials, are you concerned about a majority of this population having diabetes-related morbidities like hypertension or obviously hyperglycemia that would affect vascularization of the device?
Yeah, so two good questions. So one was, are we worried about, essentially tumor formation from the cells? And that's why we go to great lengths to make sure there aren't stem cells there. So that's been a concern by the regulators early on, about 10 years ago, when cell therapy first kind of started going out to the regulators. There was a lot of holds put on clinical trials and all because they wanted to see, is that going to be an issue? Is there going to be a formation of tumors or malignant cells? That really hasn't panned out, and it's probably because, again, we're good at making sure stem cells aren't there. Interestingly, with the device, our cell-stable device, it gives a whole nother level of safety, because if we did get, for whatever reason, a malignancy in there, it's in the device. We can see it. We've actually shown that we can image that and then go in and pull that device out and lock all the cells. So that gives us an extra level of safety. So I'd say it's a concern, but it's one that hasn't really panned out. And now you find the regulators, very seldom raising that as a major issue. On the other one, comorbidities and stuff in terms of vascularization, sure, that's an issue that we watch, and that's where we look at that in the clinic. We haven't seen that as an issue yet, but it's certainly something that we would watch for. So the idea is that in some type 1 diabetics, especially in more advanced disease, they sometimes have vascular disease. We need to get this device vascularized. These cells are, when we put them in, they're progenitor cells. So you can think of them as similar to the cells that are normally in a pancreas as in an embryo as it's forming. So when that organogenesis is taking place, an important thing that organ has to do is recruit the vascular network to it, or the organ is not going to survive. And so these cells are putting out androgenic factors, various factors to recruit that vascular network to it. So we think that should overcome those issues.
There was a question, Dave. Go ahead, please.
I have one question. On your chart was from the Alliance of Regenerative Medicine that most of the cell therapies are in neuro diseases, which surprised me a little bit. Can you, either one of you, tell us a little bit more? What is the advantage there? Because the blood-brain barrier, how would you apply it there? And I know we have in San Diego several approaches. We work on neurons and Parkinson, but I found that very interesting.
There's a lot going on in that area. Part of the rationale there may be that it's an immunoprivileged site by nature. So a lot of the concerns that come in any kind of a transplantation scenario, unless you're using physical barriers or some sort of preconditioning, etc., are not necessarily relevant for doing transplantation into the CNS. And there's some exciting data that have been published, including some data from laboratories here in San Diego, for instance, on on Parkinson's disease, also on spinal cord injury. Some recent data that was published last year for UCSD. So I think that the naturally sort of immune excluded nature of the nervous system probably explains why a lot of the early work has been done now.
Go ahead. I wanted to move on to the economics component of the discussion as well. So go ahead. Oh, I'm sorry. Go ahead.
This may be a little off base, but you're talking about transplanting cells into the patient and having that help rejuvenate or cure, in this case, diabetes. Have you thought of processes or methodologies that could allow the body to rejuvenate its own cells through focus on the mitochondria or the ATP production to get good cells reproducing itself rather than transplanting from external sources?
Yeah, absolutely. And there's a lot of work going on and has been going on for at least a couple of decades in that field. It's tough. In the case of diabetes, there's work to try to transform cells in the liver into beta cells, for instance, and such. And some of the early work on that looks interesting, but I'd say it's still quite a ways off in terms of being viable. Also, in type 1 diabetes, typically by the time you realize somebody has type 1, they've already lost most of their beta cells. And if you replace them, then you have to deal with the immune, you still have the autoimmune disease there, so if you generate them. But the whole idea of what you're talking about is certainly another big innovative field that has come on in the last 5 years or so. Some of the highest valued biotech companies and these unicorns with multi-billion-dollar valuations are in the gene editing space, where the idea is to be able to take and use things like CRISPR technology to go in and edit the genome of cells, and in that way you could potentially transform the cells or fix, quote unquote, fix the cells using gene editing, using in vivo gene editing, where you edit in the body. That's still a lot of work going on in that. There's a lot of safety questions associated with that and such. A lot of those companies right now are looking at ex vivo gene editing, which is what we're doing, where you edit the cells outside the body and then put them back in, because it gives you an ability to screen them, to purify, make sure you're putting in what you want to put in and avoiding any major safety issues. So, but this is we're evolving at an amazing rate right now. I really do think we turned the corner in medicine over the last decade or so, and it's a really exciting time.
Yeah, and I think the distinction maybe is not quite as clean as we thought in the past. That it could be, I think it will be, that in many cases it's not sufficient to transplant cells, and it's not sufficient to remodel the environment, but it's necessary to do both. I mean, a lot of what's happened in the muscle field, for instance, was resulted in an understanding that you can put healthy cells into an organ, but if you put it into a diseased organ, they don't maintain their potential for fixing whatever abnormal process you're looking at. So probably what we'll move towards is a combination of drugging the environment and providing cells that restore function.
I know there are many more questions, but I wanted to pivot the discussion towards the economics, financing. You both have raised funds in the private markets, and perhaps thinking about public markets. I wanted to hear your thoughts, perhaps for the benefit of the audience, those who are thinking about starting a business, what guidance, suggestions you might have for them in terms of raising funds in this space. Kim is not here. She just funded a company from Jim Lawrence Lab, Aspen Bio. She would have been fantastic. In the absence, Paul, you have recently raised funds.
Yeah, so raising capital is a full-time job. It's never as easy as you'd like it to be, but it is it's a really interesting time, and there is a bit of the haves and have-nots going on. In this field, in the gene editing and cell therapy field, you're seeing a lot of interest from investors. That doesn't mean that you can just go out, give them a piece of paper and they're all going to sign on the dotted line and fund it and all this stuff and work really hard. But there has been some amazing, events that take place. Some of you may have seen just recently, there was an announcement on Sana biotechnology, biotech, the exact name is, but it's previous founders of Juno. Juno was a company that was bought by Celgene for many billions of dollars, and then Celgene was bought for $73 billion recently by Bristol Myers. So the individuals that were involved with Juno now started their company. They have a Series A financing that they're expecting to come in at somewhere between $800 million and $1 billion for a Series A financing. And this is not a rarity at this point. I mean, before it is a rarity. It's huge. But before that, we had Blue Rock about a year and a half or 2 years ago, I think, that Blue Rock. Yeah, Blue Rock, which raised a Series A of $225 million. So you're seeing some of these investors really putting money into this space. My company, we did a series of financing that ended last year for about $100 million. But I can tell you it was a tremendous amount of work. That was over a year of diligence, working with investors and bringing that syndicate together. So, the capital's out there. There's certainly a lot of excitement about this field. I think it's a great space to be in. Either as an entrepreneur, that may be wanting to start a company, but also for people who want to work in a company. We had one of our directors go get recruited to a gene editing company in Boston, and I know he got a 7-figure starting package to go to that company. So, there's a high demand for these talents and this expertise.
That reminds me of the sequencing organizations just a few years ago, but again, it was never at that level. We are seeing some therapy, especially with CRISPR-Cas technology being so simple, it definitely changes the field.
Well, if you knew about machine learning, you probably could have made that 8 figures.
You're exactly right.
I think someone summed it up by saying it's less but more. Fewer transactions.
Okay.
I'd rather have more transactions than $1 billion, not more.
We buy right in the 850.
Go ahead, please.
So how do you think San Diego is looking? We have a lot of startup cell and gene therapy companies. You're seeing a lot of growth in the area here in San Diego. How enticing do you think San Diego is for them to stay with their commercial manufacturing? Do you think they'll stay or leave?
So that's been a point of debate in San Diego for decades. We're great at starting companies, we're great at building technology and building these up, but as soon as a company gets to close to the commercial phase, unless you're a company supplying cells, they often get taken out and bought and sometimes moved. I hope that will change over time. We're manufacturing here in San Diego. We're just getting ready to expand into a new site to expand our manufacturing capabilities, but that's still clinical. And when we get to commercial stage, we'll have to look around and see where it makes sense to locate.
I know that UCSD has a advanced manufacturing facility that seems to be up and running. But you're right, the San Diego ecosystem ready for more of those organizations.
Quick follow-on, you said we'll see when we get to commercial manufacturing. What are some of the factors that we should be looking at and whether you should stay in San Diego or elsewhere?
So, I'm sorry, say your question again?
Sure.
You said that when you get to the commercial phase, you'll consider whether you should still stay in San Diego. So I'm wondering what factors keep you in San Diego. What are
once you get to commercial manufacturing, it's some of the obvious ones. It's the tax structure in the state. It's the cost of living and such. Whether you put a manufacturing. In our case, that may not be such a major issue because the product itself is going to be a pretty high-tech product. But it just depends on what you're manufacturing and all, whether we sit here. Don't get me wrong, I think San Diego is a fantastic entrepreneurial environment that is very conducive to starting and forming companies, and I believe that over time it will see companies finally stick around and keep going. And we've certainly had instances of that, and I think that will increase.
Since I have the mic, let me ask one more question. You said you raised $70 million. How much of that came from San Diego?
Zero.
So that's why Steve and Misty are in here too, because if we need to change that, right?
But capital moves. I mean, I wouldn't worry about it. That actually, I've been involved in San Diego biotech for 35 years. I'm on the board of Biocom. I'm on the board of Connect. I've been on the board of Bio, et cetera. So it's been a continuous thing of getting the investors to locate in San Diego. We get some, but not that much. So a lot of times you go to San Francisco, you go where the money is, but it comes. I mean, especially when it's minus 20 back there.
Anything from you guys on the subject?
No, I think Paul's covered it.
I had a question about the CERM involvement and how CERM has impacted or influenced the whole process in California, in San Diego, and now that it's coming to the end of its life. I don't know what the outcome will be. Are you apparently received some funding from CERM?
No, I see a little bit more of it on the clinical side. I think there's a big infrastructure that's being built out at UCSD for translational studies. The idea being that that's been a major roadblock to proving out the science, honestly, turning it from a boutique thing into an actual science. And the idea being that if you build the translational infrastructure, then that will increase the hit rate of a lot of the preclinical work that's being funded by CERN. I still don't know that that's actually materialized. There are some success stories now. There's Serumtuzumab that was developed with some funding, and there are some good translational projects underway. But I had a related question that perhaps you could speak to, which is CERM investing in? I know they participated in the construction of the manufacturing facility here, but are they going to go deeper and deeper into the development process and try to really guide cell therapies all the way forward?
Yeah. So CERM, I'm a strong supporter. I'm biased because they have put a lot of capital into our program. Actually, it's more like around $80 million that CERM has invested into our program over the last decade. And I do believe that that's been really, really important for us. This funding is great, but we went for many years without venture funding, without having a hard time getting the investors to step up. And CERM and also JDRF, these research foundations, really stepped into that gap and helped push us forward through what's often called the valley of death to get us into the clinic and get us to the point where the investors that we just brought in were like Bain Capital, Mari Capital, and TPG. These are three major funds. The only reason they're there is because we have that capital to push us forward. And in fact, the translational work that you talked about is actually happening. We did the first clinical trial at UCSD with some support from CERM. So yeah, I think it's very important in terms of will it go down? Is it getting more development? As CERM's capital has gone down, we're now at the kind of end stages of the capital they have to invest. They definitely focus more. But the first few years was a lot of bricks and mortar for CERM. They went out and set up, labs and various other things. Then they funded a lot of research. In the last segment, they've really focused more on clinical work and pushing the development further forward. Not so much manufacturing yet, but I'm certainly very hopeful that CERM gets refinanced. I think our new governor has been a supporter of it, and hopefully the California's taxpayers will be willing to put another bond measure out there, and I think it's going to probably come in the next cycle to try to get that on the ballot and raise additional capital for CERM.
I mean, it is a unique experience in the world, experiment in the world, that is where the public has put the money with the objective of seeking the returns from that. The
So
question-
there's some precedent for that. I mean, if you look in Texas, they have something called CPRIT, the Cancer Prevention. and
Right,
Research.
but this is like so much bigger than anything. in
CPRIT
terms-
is pretty big, but I think that a lot of the political problems that develop, are not unique when you have a large pot of money that people that are representing both the funder as well as are applying for the funds. It creates conflicts, and then of course there comes the question of accountability and does the public have a nuanced understanding of how fast scientific progress can or should be translated into clinical advance?
That was the question. That is, how does the public know that what they have written the check for? Are they getting the returns on that?
So CIRM is very hopeful that we can deliver a cure before it goes on the ballot again.
Right.
What is CIRM? What is CIRM? I don't know.
It's like the California Institute of Regenerative Medicine.
CERM?
CIR.
CIRM was a response, if you remember back in the Bush presidency, he took funding away from embryonic stem cell research. And California put a bond issue for $3 billion onto the ballot to raise capital to fund stem cell research. So
Thank
that's
you.
what CIRM is.
How long do you anticipate before these technologies are a little more mainstream, covered by insurance, that people are actually getting them, they're available? And what is the timeline?
So they're now, okay, the timeline is now CAR T therapies are getting approved, and more coming.
But not covered by insurance.
Yeah, so they're covered by insurance. There's still, there's a lot of work going on in terms of how insurance is going to cover this. So for instance, with Novartis, when they first came out, they had an agreement with CMS, which of course covers many of the patients out there. This way, they had this agreement with CMS that the CMS would pay for it, the $475,000, but if it didn't work within 6 months, the patient wasn't cured, then they got a rebate and pay.
CMS meaning?
The Center for Medicine and Medicare. So, the insurance companies are out there. There are certainly a lot of discussions going on about how to pay for these very expensive therapies. Many of these therapies are targeting fairly rare disorders, rare diseases. So, they're at the stage where they're not having a major impact on the healthcare dollars. But as we expand this, type 1 diabetes, we can treat all patients. Now you're talking about millions of patients that you're treating, and then you have to start thinking about how the payer systems can work.
And so how long do you think that's going to be? Or say?
Well, we're hoping that we're showing efficacy with our products over the next couple of years, and potentially looking out years beyond the market.
Some of the pharmaceutical companies, they're subsidizing. For example, Yescarta from Kite and now Gilead is $370-some thousand, and as Paul mentioned, Novartis drug is $475,000. So these companies are beginning to subsidize. They understand these are very high amounts. The ones that are not paid for by the insurance companies. And also, one of the factors that might drive down the cost is the manufacturing. Want to be able to streamline, as both our panelists have said. If you go from one to many, as opposed to one to one, that definitely drives the cost structure towards a general population much faster.
So obviously the big issue is reimbursement from insurance companies. So for your product, it's obviously going to be more expensive than traditional insulin therapy. So how do you go back to them and say, we're offering curative therapy, how will you make them reimburse you for my insulin?
I don't know about make. I think part of what you have to do is show what value you're bringing, and there's a lot of value-based research going on. In our case, we're not looking at necessarily changing the cost of this disease that much, in the sense that you know, typically for a type 1 diabetic today, if you ask JDRF that tracks all this stuff, they're paying about $10,000 a year for their insulins and their monitoring and all the things that go into controlling type 1 diabetes. And that doesn't include the long-term complications that are part and parcel of having type 1 diabetes. So, you know, if you have a therapy that, you know, can provide essentially a functional cure over 5 years, you know, there's $50,000, $100,000. You talk about a million patients, potential million patients, you can do the math. That's a pretty significant commercial opportunity for a company. You know, some of the ones that get way up there is like the Novartis drug of the 500,000, because they're treating a relatively small number of patients, so there's a lot of cost that go into, you know, developing that technology, taking the risk and all. But it gets a big benefit back. And you know, insurance companies, this isn't new ground necessarily for insurance companies. For instance, transplant surgeries can cost, you know, $1 million to get a, you know, liver transplant or kidney transplant. It could be, you know, hundreds and hundreds of thousands of dollars. And insurance will cover that. And there's various ways they've done that, pooling and insurance and various things. And so all that's being discussed. Again, I really, if you're interested in this, I really suggest you go to the Alliance for Regenerative Medicine site and look at these white papers they did on it. It's quite informative.
Yeah, that's actually a really fascinating comparison to transplantation, which I hadn't really thought of. But transplantation is very, very highly regulated activity. And there are a lot of things that you need to do to be eligible for transplant. There are a lot of things that you cannot do if you want to be eligible for transplant. And I do wonder whether, as we develop more and more advanced therapies, cell and gene therapies, that require that level of economic investment from society, from payers, whether it's going to evolve similarly.
Yeah, I think so, and I think that's where you get into these pay for performance and that type of thing.
Right. But the patient may be part of the performance aspect of it. And what do they do to make sure that they are responsible stewards of that?
Yeah, no, I think that's all going to be.
We have time for one more question. Sharon.
Thanks, Hi guys. So I had a question about if you see that children are kind of more apt receivers of cell therapy and kind of the impact of cost regarding that.
Could you repeat that, Sharon? Sorry.
Yeah, no problem. So I kind of wanted to ask a question about whether or not children have more acceptability of cell therapy. So for example, the younger you treat them, the more beneficial the treatment might be. So what's the impact on cost? Kind of what are your thoughts on, you know, more people who are aging and having cell therapy diseases and the cost of treating an aging population versus treating diseases that, you know, younger patients have and, you know, they have a longer lifespan after treatment?
Yeah, I mean, you know, obviously the pediatric part of this is really important for type 1 diabetes. Type 1 used to be called juvenile diabetes because most of the kids that came down with it were young when they first showed the disease. Right now, we're only treating adults in clinical trials, and that's just because that makes sense to do in terms of risk benefits that we're looking at. But certainly, we expect, you know, once we show that this is effective, assuming we show this is effective, so this disease listening right now. Assuming we show this is effective, then you know, we want to do pediatric. You're basically required by the regulators at some point to do pediatric trials. So, and obviously, as you say, the benefit can be lifelong versus treating a cancer patient that's at the end of days breathing goodbye. It's not to say that's not important, but obviously treating the younger kids can have a major impact on the economics as well. You know, again, as I said earlier, one of the challenges of the payer community is they think fairly short term. They're looking at what they're paying for drugs over the next year or two and such, versus when you treat a child like that, if you give a child a curative therapy, you might save millions of dollars over the course of that life, or create millions of dollars of economic benefit to the community by making that treatment. So those are the challenges of pricing these.
Yeah, and you know, you in countries where there's a more kind of algorithmic or rational approach to evaluating the cost effectiveness of therapies, they have this idea of a quality quality adjusted life here. And obviously, if you're doing a highly effective intervention in a child, the number of years that you're buying with that is much higher. And so that obviously drives the number of qualities up and the cost per year. Yeah.
One more. Related to this is that with this California, you can see that initiative for Medicare for All coming up. How do you think this would impact your industry, positively or negatively?
So the question was, Medicare for all, and the good thing about it.
Your funding, your approach to treatment, everything, how would it?
So what you're talking about is essentially nationalized health care.
In California, not all over the
Whatever you
US.
want to call it, a government
So
sponsored program. Government sponsored program. You know, the politics on that is not something I wish to get into. You know, I think in terms of, you know, our industry, what we think about when we think about that is, you know, this is a very expensive endeavor that we take on when we're developing medicines. As I said, you know, our company has been at it for almost 20 years to get to where we are today. You can imagine the costs of that and such. And so for investors to be willing to put that kind of capital to work, they have to see a pretty high return to take that level of risk. So, you know, the issue that we worry about when you talk about Medicare for all and such and single payer systems is, you know, is the world going to pay for these drugs? And the U.S. subsidizes a lot of this right now, absolutely. But, you know, we need to get a fair return in order to get the investors to put the capital.
Sorry to get to all your questions. You really have to leave this room. I want to thank panelists. Please give them a hand. For coming and participating in the conversation. There will always be